because I think there is still a culture of fear. Even though we do say that we should look to identify the role of systems and processes when it comes to human error, we still do have a blame culture.
Hello, you're listening to the Dental Protection Podcast, and this is the In Dentistry series where we are looking at diagnostic errors, which are often the drivers for the cases and claims that we deal with for members. The next few podcasts will be focusing on different clinical areas of practice and looking at some of the specific issues that arise and how these might be avoided. My name's Yvonne. I'm Deputy Dental Director and Dental Underwriting Policy Lead here at Dental Protection. Today, I'm delighted to be joined by Dr. Rattain. As you will know, Raj is the Dental Director here at Dental Protection and has had a wide and varied career encompassing clinical dentistry as both an associate and practice owner, as well as consultancy and advisory work for the NHS, private and corporate dental care. Prior to being Dental Director, he was also a dental legal advisor for Dental Protection for over 20 years. He has also authored numerous articles and books on various aspects of dental practice, including risk management and governance. In this first episode, we're starting with a high-level view of why diagnostic errors can arise and some of the more clinical issues or perhaps cognitive reasons that can drive decisions we make and what situations can promote errors arising. Now, based on the cases we see at Dental Protection, there are two main areas where we see allegations that relate to diagnostic errors. First is the alleged error in assessment and the diagnostic process itself that can lead to patients getting an incorrect or delayed diagnosis. Secondly, we have allegations that relate to breakdown in communication between team members or between the practice and the patient, meaning the patient doesn't actually get accurate or complete information about diagnosis and treatment needs. So first of all, welcome Raj, and thank you for joining us today. And I'd be interested just as a starter in your thoughts on the term diagnostic error. And I think one of the questions that always arises, and I think both you and I have seen these as dental legal advisors, is whether an error has actually been made or whether it is actually simply a difference of clinical opinion that has led to two different versions of what treatment the patient should have actually received. What are your thoughts on that?
Thank you very much, Yvonne. Thank you for that very kind introduction. We discussed previously what we were going to include, and despite our preparation time, it's just occurred to me actually that when you said about that we do sometimes make errors and so forth, I think it's also worth mentioning that one of the items that's frequently omitted from the clinical record is the diagnosis. Sometimes dentists will make a note of what the patient is presenting with and then jump to the treatment without actually recording the diagnosis. So I think perhaps, as an opening message today, it's worth mentioning that it's important to make sure that the diagnosis is written, and because its omission on the record card can compromise the way a case is managed. Having said that, Yvonne, I've forgotten your question. So what was your question again?
It was really about diagnostic error in itself. And
yes,
the problem that we have in dentistry is that there are so many different potential diagnoses that it may be just a difference of clinical opinion rather than an error being made by one clinician.
I think you're absolutely right. I think this very word error implies some form of deviation from a particular path or a particular conclusion. And sometimes that deviation can actually be due to a difference of clinical opinion. If I look back over my clinical career, I've looked at a clinical situation, I've made a provisional diagnosis, made a decision to intervene, and then when the patient has presented 2 or 3 weeks later to actually have the treatment, I've looked at it again and thought, actually, I'm not sure that my original assessment was the best option for the patient. So I think it's very important to distinguish between what is a true error, this black and white distinction of error, versus, as you rightly say, what is actually a difference in clinical opinion. One of the things I think that also fits in with this is when we look at restorations in the mouth and we make a decision whether or not a particular restoration may, for example, need changing. So you can have a failing restoration, or you can have a failed restoration. Now, most dentists would agree that when the restoration has failed, an intervention is needed and a replacement restoration is usually indicated. But when something is failing, a clinician can take a different view on that, because at what point do you decide that this is the right time to intervene? And that's where we get these differences of clinical opinion. And strictly speaking, those should not be classified as errors in my view.
Yeah, I totally agree. And I think it's a very common challenge that we see, particularly when there is transfer of patients between clinicians, that, the decision to actually just monitor a tooth versus actually intervene can be interpreted differently by a patient. So I think that's really valid. And I suppose following on from that, sometimes errors do arise. And I think the question is, what conditions are actually more likely to lead to somebody making an error in judgment, or what would promote an error arising? I'm thinking about, I suppose, your own time in practice, but also kind of some of the cases that we look at, where we see errors arising. What are the common themes there?
So it's a good question, and I'm reminded of a graph that I came across many years ago in a book called Medical Accidents. And it's a graph that I've used many times in my presentations, and you'll be familiar with it, Yvonne, which looks at generically the causes of error. And I think from memory, there were two things on that graph that stood out for me. So one was that if somebody is unfamiliar with a task, they are 17 times more likely to get it wrong. And if somebody is working under time pressure, they're 11 times more likely to make a mistake. And I think those two bars on that particular graph, even though it's taken from a book on medical accidents and it's a different reference, I think they absolutely apply to dentistry.
Do they tend to, I suppose, are they cumulative? So we end up with, the inexperience and the time pressures. And does the risk actually exponentially increase there? It isn't just a sum of the two.
I think you're absolutely right, actually. I've never thought of it like that. So basically what we're saying is that the combination is greater than the individuals added together. It creates almost bizarrely almost a synergistic effect when it comes to compounding the error rate. Yes, I agree. I think that's absolutely the case.
Interesting. I think when we spoke before, when we were talking about the episode today, we talked about motivational blindness, which was a concept that I found really interesting, about what might drive, I suppose, the diagnosis down a particular pathway. And I just wondered if you could expand a little bit more on that in terms of an example of how motivational blindness might impact our decision making.
Yes. Just on your last question, Yvonne, if I can just quickly add another element. So, we talked about time pressure. We talked about unfamiliarity with the task. It occurs to me, actually, there's a third element as well, which I think is something that certainly we've talked about from a risk point of view within dental protection many times. And that is the threat associated with overconfidence. Particularly when people start to provide treatments and then learn techniques where perhaps their training is not been to the depth that it needs to be to deliver care safely. So I think I would add that as an emergent factor. And I think in years to come, we will look back and probably be able to identify that as a contributory element when it comes to cases and errors. Motivational blindness is a psychological term. It's an interesting term. It's basically relates to the psychological mechanisms that come into play when we make decisions. So it is a type of cognitive bias that says that people see what they want to see, I guess, and miss information that's contradictory to what they want to believe. So, when a person suppresses information, when it's in their interest to remain ignorant, that is known as motivational blindness. And it's the use of the term, it's often associated with unethical behavior.
I wonder if you could perhaps give an example of where motivational blindness might come into practice in terms of provision of dental care.
I think the one example, bearing in mind that the term is often used for looking at sort of ethical aspects of clinical practice or ethical aspects of decision making, I think I would use, for example, NHS targets as an example. So, for example, you could have a situation in a practice where a dentist observes unethical behaviors due to motivational blindness, ignores them because the unethical behaviors are making it easier for the practice to reach its target. Another one might be where the risks associated with certain treatments are overlooked or underplayed in conversations with the patient. The way the conversation is done with the patient is it's framed in a slightly different way so that the risks are not presented at the level that exists, but are, as I said earlier, underplayed.
That's interesting. So we've talked about, I suppose, motivational blindness being linked to, I suppose, unethical behaviour, but I wonder if there's also, a behaviour that it's not a conscious decision to actually go down one particular direction or another. And I'm just thinking about the impact of perhaps, patient pressures, that a patient will come to the practice and they've decided they want a specific, I'm going to say, cosmetic treatment. And is there a risk that that actually sets the clinician going down that particular pathway of treatment, and it pushes them away from taking that step back and providing that objective assessment, the full diagnostic process, because they're already committed to going down that particular route? And it's not unethical, it's just, it's the way that the conversation is actually developed that directs, it's almost like a tunnel vision that's, I suppose, been introduced into practice.
I think that's a very good example, Yvonne. I agree with you completely. And I think, if the patient's expressed preference is aligned to what the dentist wants to provide, because it's perhaps an area of interest for the dentist, then it's more likely that both parties, when they do their shared decision-making process, will conveniently ignore the risks associated with the treatment, because they both have a clear preference to have that a particular option. And you're right, the challenge then is to pause and go back to the start of that diagnostic process and to make sure that all the different areas are covered.
I think it goes back to your time challenges you talked about earlier, that, when you're on a limited time, then it's an efficient way, isn't it, to just bypass the options that the patient hasn't been interested in.
And the same bias actually creeps in sometimes when dentists, when they're treating good friends or members of their own family, there tends sometimes to be a shortcut when it comes to consent and discussion of risks. And it takes a certain discipline to pause and think, actually, no, I've got to follow my path and I've got to go through a checklist almost of different aspects of care.
Absolutely. I think probably both seen several cases where it's been family and friends that have been the patients, and you see that lack of information in there. I was just going to take a slightly different tack for, I suppose, the next question. And you'll remember that I think it was back in 2018, we did a survey. I think it was about 1,000 members of Dental Protection. And at the time, 9 out of 10 of those that actually replied to the survey said they were in fear of being sued by patients. I think what stood out for me was nearly 3/4 of those actually considered that the fear of being sued was actually impacting the way they practice. And I suppose the question is then, are people practicing defensively to try and reduce the risk of being sued? But conversely, is that culture of fear actually risking errors in diagnosis because, again, it's almost that tunnel vision that you stay away from the treatments that you think might be more risky and favour another type of treatment? And I just wondered if that is almost captured by that blindness again, that it's affecting the way that we actually practice.
I think fear of failure is a very, very underrated aspect of clinical care, actually, because it's impossible to quantify how and then measure the impact that it actually has. But we know that fear of failure is a significant issue with dental undergraduates, even at dental school, and those individuals are our future dental professionals. There was a report in 2020 called the Good Childhood Report, and it reported that British teenagers, if I remember correctly, have the lowest life satisfaction in Europe. And this was in part due to the fear of failure. So, it's a societal challenge. It goes beyond just dentistry.
Very sad, isn't it?
It is sad, yes.
So I suppose trying to move on to a slightly more positive approach, we've talked a lot about what might lead to errors being made. What conditions are more likely to, I suppose, promote good practice and avoid those errors arising?
I think it comes back to that concept we said earlier, isn't it, about having more time. And there's a classification for challenges in practice that I came across in the 1980s. It was very shortly after I qualified. I still remember the reference. It was Messrs. French and Kaplan. I don't remember the third author, I'm afraid, and they use a phrase which they described as quantitative overload. So quantitative overload is too much to do in too little time. And it's working too fast or too hard. And qualitative overload, which is the feeling that somebody has that they don't have the time to produce quality work or don't have the skills to perform quality work. And, even though we've had lots and lots of work on stress and error management, I still believe the challenges can be summed up with those two words. I think it's all about quantitative overload and qualitative overload. And, I would refer listeners to that paper in early 1980s, French and Kaplan. Oh, and Harrison. That was the third author. I've just remembered the name.
I suppose it's tied into, if you're avoiding the overload, then it impacts upon your well-being,
Absolutely.
avoiding burnout, which are factors that are inevitably going to impact on the way you deliver care.
And I think, in answer to your question, what can we do to reduce the incidence of error? I think that those basic principles will go a long way towards making clinical practice safer, error-free, but also, if I may add, more enjoyable. And I think when work is fulfilling and enjoyable, I think that creates this positive mood, and that in itself will suppress the tendency, because people are working in they're being disciplined, but they're working in a relaxed environment, and you don't get the environmental factors that we have talked about so many times in our webinars over the years.
Wholeheartedly agree, Raj. I suppose the other element from an environment perspective, and I suppose driving positive changes, is actually learning from errors and near misses, learning from colleagues, learning from kind of the wider practice environment as well. How well do you think we actually put this into practice as a profession?
My personal view is that I don't think we do this very well. I think we pay lip service to this idea of learning from near misses in dentistry. Now, we don't have a centralized reporting system. I think some form of centralized reporting system would help. And I think we need to sort of be more respectful and understanding and more forgiving of error as well. Because I think there is still a culture of fear, even though we do say that we should look to identify the role of systems and processes when it comes to human error, we still do have a blame culture. And I know we've had, probably, I don't know, at least a decade of publications saying it's not about blame, but I can't help feeling that that's how most people feel it still is.
And that in turn doesn't help with kind of reducing the overload on you, that you're pressed to actually outperform, aren't you, all the time? And we can't. We just physically can't.
And Yvonne, both you and I, over the years, we've both spoken to so many members when we've helped them when they've telephoned in our sort of dental legal consultant days. And we know that, that members, dentists find it very difficult to accept that they've made a mistake. They find it a very painful process. They They punish themselves, they blame themselves rather than looking at it in a more objective way. So, it's in a way, it shows that the profession is committed to providing high standards of care. That's why mistakes are so painful for a clinician, because we do aspire to high standards of care as a profession. And it is perhaps the slight myth or even the curse of perfectionism.
I suppose tied into, that lack of reporting, there's an awful lot of research that's been done on errors, as you've said. But I suppose the question is, how much is actually of relevance to primary care dental practices? Because I think a lot of it is actually focused very much on delivery of healthcare in a secondary setting.
That's true. It's focused on the secondary setting, you're absolutely right. And it's also focused on the medical sector, actually. So, whilst there are lessons that we can take from medicine and we can, apply them in dentistry, there is very little source information available, very little source material when it comes to dental studies. So I think there's a bit of a gap there. And I know there are one or two people that are looking to explore this in dentistry in a bit more detail. And, I hope that research will come. But we are limited by what's happening in medicine. And you can't always make the comparison, I think. The way dentistry is done and the nature of dentistry, it's very different from medical care.
Yeah, absolutely. And I suppose just finally, looking forwards, the way that I suppose healthcare is and dental care is being delivered in primary care practice is going through change. So we're seeing kind of more, I suppose, multi-team approaches to provision of care. And I wonder if that will help, I suppose, in reducing some of the errors, because you'll have more touch points with the patient, seeing more people, and the potential to pick up any, I suppose, errors. I suppose the alternative is, does the risk increase because you've then got more handovers between different members of the team and there's a greater risk of the communication breakdown? So I don't know if it's something that you'd kind of considered in terms of risk moving forwards and, what we might need to do to actually change, I suppose, our approach to the way we deliver care.
I think handover risk is very significant in medical practice, medical care. I think in dentistry is perhaps less so because we don't have too many handover opportunities. Those handover opportunities will increase as we have a team-based practice. In a medical setting, you see the breadth of information that has to be gotten across in a handover is a lot. And I think the scope for error there is greater. In dentistry, the amount of information that you're transferring from one clinician to another is more limited. So I think the risk is probably slightly less. But I think what teamwork will encourage is a discussion amongst clinicians about the care that a patient is receiving. And I think that discussion will probably inform the clinical decision making and make it more robust and less prone to error.
Yeah, it's an opportunity to learn from each other, isn't it? Which
yes, indeed,
is always a good thing. So thank you for your time, Raj. I'd personally like to thank you for all your insights and your considered thoughts on some of the wider issues that are impacting the safe delivery of dental care. Thank you for listening to the first podcast of the In Dentistry series on diagnostic errors. Over the next few episodes, we'll be looking at specific issues that relate to implant dentistry, orthodontics, and cosmetic dentistry, and speaking to colleagues who work in those fields. I hope you've enjoyed today's episode and that you will join us for the rest of the series. If you're a member of Dental Protection and want to know more about today's topic, then please look in the podcast description for further information. If you're new to podcasts, perhaps listening for the first time, then if you subscribe to the channel to make listening easier in future, you can access this podcast from all major apps, including Apple and Google and Spotify. For more information about Dental Protection, or if you're already a member and need a certificate for listening today, then please look for details in the description. I've been your host, Dr. Yvonne Shaw. Thank you again for listening.